Hello, my name is Kevin Vogeli. I'm a hand surgeon, and today I'm going to be talking about tendon transfers for radial nerve palsy. The objectives of this lecture are to identify the donor and recipient tendons, and the second objective is to how to appropriately tension these transfers once it has been performed. The technique that we're going to be describing is the palmaris longus to extensor pollicis longus transfer, the flexor carpi radialis to extensor digitorum communis, and the pronator teres to the extensor carpi radialis brevis. This is a technique that was originally described by Paul Brand. This is a 60-year-old male who had a C7 to T1 cervical radiculopathy on the left that presented to my clinic with radial nerve palsy that had been ongoing for over a year. Making our incision anteriorly, the flexor carpi radialis tendon is identified, as well as the palmaris longus within our plane. You can see us testing the attachment of the palmaris longus. Once these have been identified, our dissection is continued proximally to identify the pronator teres in between the superficial radial nerve and the radial artery. Then a great deal of care is taken to dissecting off the pronator teres tendon from the shaft of the radius, incorporating the periosteum of the attachment site by sharply dissecting it off with a 15 blade and then a curved osteotome to gain as much length of the tendon for the transfer. This is the most delicate portion of the surgery and requires great care to obtain as much length from the tendon itself, as well as excursion of the pronator teres. You can see me dissecting out the pronator teres muscle from the shaft of the radius of this to gain as much excursion as possible to get as much length for our transfer. Next, we turn our attention to the flexor carpi radialis tendon, which is harvested as distal as possible to give us much length, and then dissected out proximally to give us more excursion. The same procedures performed for the palmaris longus tendon, transecting it as distal as possible. Now you can see clearly the three donor tendons within our anterior incision, the pronator teres, the flexor carpi radialis, and the palmaris longus. Next, we turn our attention to the dorsal incision, where the ECRB tendon is identified within the second compartment, just proximal to the extensor retinaculum. You can see us testing the insertion of the tendon such that it extends the wrist when it's pulled on. Next, we make an incision directly over the EPL tendon, just proximal to the MCP joint of the thumb. The EPL tendon is identified and protected distally. And then we turn our attention to our dorsal incision, where the EPL tendon is actually transected at its origin and brought through from the dorsal incision into our second incision over the thumb. And then the tendon is passed into our anterior incision underneath all structures, such that it comes in line with the palmaris longus tendon. After the pass has been successfully performed, the extensor pollicis longus tendon and the palmaris longus are brought together via a pulvar Taft weave. Of note, the wrist is placed in neutral and the thumb in full extension while the tensioning is performed. I like to perform one weave, which is secured with a single 4/0 fibro wire in a horizontal mattress fashion, and then assess the tension of the transfer prior to performing two additional pulvar Taft weaves, which are also secured with 4/0 fibro wire in a horizontal mattress fashion. Next, we turn our attention to the flexor carpi radialis tendon, which is passed from our anterior incision to our dorsal incision, being careful to place the tendon underneath the superficial radial nerve during the pass. Then we turn our attention to the fourth dorsal compartment containing the EDC tendons. You can see us checking each tendon to make sure that all tendons have been incorporated. And then a single horizontal mattress suture is placed through all EDC tendons to make sure that they are all included in the tendon transfer. After we are satisfied that all tendons have been captured and are involved, the FCR tendon is passed through the EDC tendons in a pulvar taft fashion. Great care is taken to make sure that we incorporate each tendon through the pass. This can be difficult as the FCR tendon is bulky and there are 4 tendons to pass through. Much like our other tendon transfers, a single pulvar taft weave is performed and secured with a 4/0 fiber wire in a horizontal mattress fashion. Please note that the wrist is held in neutral and the fingers in extension while tensioning the transfer. After we secure a single pulvar taft weave, I like to check the tension of the transfer to make sure that the fingers go into full extension as the wrist reaches neutral. This will give a good extension of the fingers and still allow the patient to make a composite fist after the transfer is performed. After a single transfer is performed and we're satisfied with our tension, 2 additional pulvar taft weaves are performed through the EDC tendon with the FCR and again secured with fiber wire non-absorbable suture. This is our final tendon transfer, which we pass the pronator teres tendon into the dorsal wound, once again underneath the superficial radial nerve, and passed into the ECRB tendon in a pulvar taft fashion. Please note that this transfer is tensioned with the wrist in full extension and secured with a 4/0 fiber wire in a horizontal mattress fashion. 3 passes are made in this fashion, and after our passes are made, we like to arrange the hand and the wrist and make sure that the fingers become into full extension at neutral. The reason why the pronator teres transfer is performed last is because it is the most difficult to perform, and additionally, we do not want to be ranging the wrist while performing the other tendon transfers, putting additional stress on the tendon transfer. The patient is then closed and put into a volar slab splint with the wrist in extension and the fingers in full extension. The patient will be seen back in 2 weeks for wound check, suture removal, and to begin a supervised hand therapy regimen. After completing a supervised hand therapy regimen, the patient was able to achieve active extension of his wrist, his fingers, and his thumb at 3 months, and able to make a full composite fist as well.